Hi, this is Dr. Toby, your host on Health and Wellness. What a delight and an honor to have you on our show. We're so privileged that you're here to see this show with Dr. Charlene Collier. Dr. Collier is an obstetrician trained in some of the best Ivy League universities in the country, did her undergrad medical school at Brown in New Hampshire, went on to Harvard to do a master's in public health, and then after her residency at Yale University in Connecticut and post-op she went up to do a 2-year fellowship in maternal health with another master's in tow. She's been working in the Mississippi area, the director of the Mississippi Perinatal Healthcare Collaborative. And she's worked also at the University of Mississippi Medical Center. She is a delight to listen to. She's a mother, she's a wife, she's a daughter, she's a sister, she's a physician, she's a public health advocate, and she's an obstetrician who cares for her community. You don't want to miss this. Jesus is Lord. Hi, this is Dr. Toby, your host on Health and Wellness. Don't touch that dial. We have an awesome show with Dr. Charlene Collier. She's a woman whose litany of degrees will literally fill the room. I mean, she went to Brown University, on to Yale for residency, and after medical school at Brown as well. She did a residency at the Yale University in obstetric gynecology, got a master's in public health from the famous Harvard University, and then did a 2-year fellowship that also gave her another master's. And she's worked in the Mississippi area in perinatal collaborative to ensure and improve maternal mortality. And that's one of the main reasons we're talking about maternal mortality. Just last month or 2 months ago, a lady died named Bowie Tori. And she died from complications from what we heard from the autopsy, I think, of preeclampsia at 8 months of gestational age. Now, what's unique about Tori Bowie is that she was a former world champion 100-meter star, and she died in Florida. Now, why would a woman who had so much access to health and maybe financial capability as well die at 8 months of age? That is the question.
Yeah, so I've reviewed many maternal deaths, so even with the results of that finding of what led to Tori Bowie's death being eclampsia or preeclampsia, so many questions remain, and preeclampsia certainly is a deadly condition. It is a high blood pressure condition that affects all the organ systems. You can have seizures, kidney failure, liver failure, respiratory failure. And certainly it can lead to the death of a mother from stroke, very high blood pressures that can lead to stroke. Some of the symptoms leading up to preeclampsia can be vague and can be similar to pregnancy symptoms, minor headaches, a little bit of swelling, things that many pregnant women experience. And this often leads to people not always believing a pregnant person when they call and say, I'm not feeling too good, something's wrong, and they're told it's okay, and then it progresses. And so that is a common experience, that people know something is wrong, they do reach out for help, and they get told it's okay, or to go home, or just rest and not worry. Now certainly we don't know what happened to Tori in the moments or days even before, but as someone who's studied this, and I've read records, I've interviewed family members or worked with those who've interviewed family, I'm also very curious about what happened before, and then pregnancy is being pregnant is a social experience. You have to have connections, people who you trust, people who are there to reach out to support you. And it can be a lonely, isolating experience. Not everybody enters pregnancy excited about the baby or having a best relationship. Depression, maternal mental health is a significant problem. In fact, one of the leading causes of maternal death as well. So, having that network, that community of people who can help you. And so if that's not there, you're at higher risk of falling through those cracks. So there's a number of things, of course, now. Eclampsia, strokes, they can come on all of a sudden, no warning, or not, as many warnings as
Well, the
someone
reason
can
why the
act
whole
on.
world was shocked because they think if you're a runner, you're healthy,
No.
if you're a champion athlete, you're wealthy. If
Hmm.
you're 32, you should be at least knowledgeable about healthcare. So people were just shocked.
Well, yeah, and I mean, I think it gets back to again what we see with this black maternal health crisis and black women being, anywhere from 3 to 8 times as likely to die. And that is not because of a genetic issue. This is a systemic effects of the racism, stress, just not being, at the center of healthcare. Even if you can gain that trust, we see Beyonce experienced it. Serena Williams experienced it, where she had a pulmonary embolism, a big blood clot in her lungs. And she knew it because she had one before. So here you have, she's wealthy, she's educated, she has experience. So she knows her body and tells her clinical team it's happening, and they told her, no, it's not. And she could have absolutely died from that. She would have been in the same boat, and where everybody would have been like, well, what happened to her? But her story would have been, and maybe no one would have known that story, right? If thankfully she lived to tell the story, but many don't, that they knew something was wrong, and someone didn't believe them. And that experience is much more common for black women, that we see that they
So let's
reach.
just review the statistics.
Yeah.
According to the CDC, America as a whole has a infant mortality rate of in 2021 32.9 deaths per 100,000 live births. That's mothers who died.
Maternal
32.9.
mortality, yes.
This number 32.9 was up from 23.8 in 2020 and 20.1 in 2019. Now, the biggest statistic that gives me concern is that while the average mortality rate in America in 2021 is 32.9, the African American woman mortality in 2021 was 69.9, which is almost more than double, almost 2.6 times the rate of a Caucasian female. And they go to the same hospitals. Now, the average man on the street will say, well, more comorbidities.
The
Health,
comorbidities are there, and I certainly see them. But that, as a clinician, if you know a comorbidity is there, your level of care should then match that. It should meet that. You should provide more, closer follow-up. You should listen to that person all the more, right?
And comorbidities just mean
other
other diseases,
other conditions.
with
So
the pregnancy.
if a black woman has a high blood pressure and she calls saying, I have chest pain, that's the one you should flock to. You should be calling her in, bringing all those services to her. Instead, what we see is, yes, they have a comorbidity and they call for help and they may not get it. So that happens. Or let's say that comorbidity is there, but they've been in and out of the health system and no one's addressed it for their entire life. It's accepted, this level of illness. So that's a lifetime issue. Or because they're living in a community where there's not, safe environment to exercise. You say go eat healthy, where there's food deserts. So they're stuck in these situations that are often driven by these historical policies that have let those communities not have access to health. So some things are related to long-term effects of racism. Some things are happening in the moment where they're not being heard. So it isn't just, okay, they're so sick they should die. No, it doesn't happen that way, just so simply that because they have obesity or hypertension. We have treatments for high blood pressure. We have good medication for diabetes and high blood pressure. It's, how does our health system treat people? How does it address it? How does it make it easy or make it really hard? And for some segments of our population, it's a lot harder to get good care. Even if it's down the street, if you walk in those doors and people don't look you in the eye, don't say your name, don't acknowledge your partner, call them the baby daddy, and don't treat them like they're, maybe you're not going to listen as much when they say go pick up that prescription. When they discharge you, say go take those meds. Maybe you're not as encouraged to come back to the doctor when those symptoms start up. So all those things work together. It's not an excuse at all. If you say, okay, there's obesity or there's high blood pressure and that's why they're dying, it's also, well, why are those conditions accepted in this population? Why are they not, thinking, well, it takes more work. Let's get people plugged into care earlier. Let's make it easier to get prenatal care. Let's make it closer to home. You know, we work in Mississippi. I drove out here 2 hours. I have patients that drive 2 hours for appointments with me. You know, 2 hours where they're worried about their job because it wasn't protected. They're worried about their child care. Are they going to get back? You know, so these are stresses that are also
Do you
very
think the
difficult.
teenage pregnancy crisis is a reason? Because we know that America has the highest teenage pregnancy rate in the Western world. I think it was 32 or something for uh, something really high, maybe 1,000. So, do you think having children at an early age, maybe more, and I have to look at the statistics, maybe more in the African American community than the Caucasian community is another potential reason?
I don't see a lot. We know that being young, also you have fewer comorbidities, so we don't necessarily see that that increases their risk of death, maybe at the extremes, but older age, yes. Like the older a person gets, above 35, 40, their risk of death from pregnancy goes much higher. Teen pregnancy is more of a social challenge because of the lack of education that comes with it, the lack of social support, the lack of, you know, the cascade it puts somebody on in their life course that can end up being health problems later, right? If they're not, if they don't finish high school, and then that child is raised in a single family home, there's less income. And so there's this social cascade. But medically, a 17-year-old doesn't often have the morbidities of a 37-year-old. So I don't often, you know, we don't look at those numbers and see teens are driving maternal death.
Okay.
You know, at the extremes, they have higher rates of some of the preterm
So it's actually
birth.
the older women that have higher mortality.
Yeah, which is a big concern, as you mentioned earlier, about going to med school, graduate school. Black women are some of the most educated people in this country and graduating school, and we do see some of that delayed childbearing can play a part, but it's not the only answer. It's a very layered problem.
Wow.
But I think certainly what we do need to think about with our teens is their overall health. You know, your family medicine, you take care of obesity, and, you know, if they're not set on a path to be healthy before pregnancy, we only have, at best, those 10 months. You know, we say due dates when you're 40 weeks. So we often don't get people into prenatal care. So we have maybe, if we're lucky, 8 months. That's not going to turn around a lifetime of health problems, you know. So we need people to be healthy when they get pregnant in the first place. And that goes way before they enter my office. That's the community they grow up in, the food they're around, the stress they carry. So we have a lot to do to create healthier, you know, communities, and that communities can take care of themselves and each other.
Right.
So that's the big picture solution.
Right.
But there are solutions at that level when you're pregnant, you know,
So
things
let's
you
go
can
back
do.
to the 32-year-old,
Yeah.
Miss Tori Bowie.
Yes.
She died alone. That's another thing that shocked me.
Yeah.
Are we living in an age where there's a lot of single pregnant women,
Oh, definitely that.
unsupported?
Yeah.
There's it's almost like a vacuum, a social vacuum, because I find it hard to believe. I think they said they found her 2 days after.
Yeah. It was very, very tragic to
Did she
hear
have
that.
a loved one? I mean, the father. I mean, again, like you said, medicine is a multifaceted thing. We look at it. A lot of us look at the surgery, pharmacology, but the social structure, the social construct,
Yeah.
is just as important.
I mean, I think as a society, we've lost a lot not being in community, you know, and they say it takes a village to raise a child. Well, it takes a village to care for a pregnant person and to have that, you know, you got your family around you, your loved ones around you. And certainly being, you know, if you're single, you don't have a partner, that adds a layer of complexity. But always not being married doesn't mean you don't have
Doesn't mean-
support, right? You
right.
can have a very loving, supportive partner. But if in those moments you don't, absolutely, it's so much harder. You're tired, you're fatigued, you don't want to get up. Who's going to help you? Yeah, I've been, you know, pregnant twice. There's times where you're just like, somebody bring me something to drink and eat, and or just that pick me up. So absolutely, the isolation is a big problem. People just feeling alone, just not having the help they need. I've had pregnant patients call me like, I have no one else to call. You know, my bills are not getting paid, my lights are going to be shut off, they're going to take my baby away. And as a doctor, I'm like, I don't have anything for that. You know, I don't have, patients nearly, wanting to take their own lives because of the social stresses. So that's why we can't think of healthcare as just medical
One
care.
size
It's
fits
not going
all.
to fix
Right.
that. You need to embed the social, supports
Support.
and
Yeah.
acknowledge that it's needed. So, and then it isn't just about poverty, to your point about anybody who is alone is at risk. And we went through this with COVID, there was a lot of challenges when people were in health systems by themselves, right? Like people were at one point having babies by themselves. So having someone with you actually is a protective factor. Someone who can hear the
Right.
questions, ask the questions, advocate for you. So advocates are so important, and I don't want to see anybody alone through any of their pregnancy, journey, because no matter if you're rich or poor, certainly more, I would say, if you're lower income, and because people don't treat them the same. It's the truth. It's just sad, but it happens.
Yeah.
But I think. I know that they'll do a very thorough review of what happened with her, but I think it certainly points out that we have to, wrap our arms around our people and pregnant
Yeah.
people.
I
And
trained in New York, and I didn't know my neighbor. I lived in a brownstone. I didn't know my neighbor for the 5 years I was in Brooklyn.
Yeah, yeah.
I jumped out of my house. I was in residency, so 5 a.m. Got back like 9 p.m.
Yeah.
And weekends, I guess I just slept all weekend and
Yeah.
went to church. But I for 5 years, I didn't know my neighbors.
Yeah.
That was how socially apart we were.
And it doesn't always take a doctor to check on someone, are you okay? And if they say no, then that person can step in and say, let's get you help, I'll make the call. Like, so having that support is
Dr.
so
Alexander
important.
was on my show, the
she's
cardiologist
great.
at UMC, and she talked about a project she's working on at UMC, University of Mississippi Medical Center, on cardiovascular health in pregnant women.
Yes.
So the statistics show that 26%, this is a Mississippi statistic, I think, 26% of pregnancy-related deaths are secondary to heart disease.
Yep.
26.5% of pregnancy-related deaths. And these are women probably mostly under 40.
Yeah, absolutely.
Are related. And most of us don't think of pregnant women under 40 as heart disease patients.
I mean,
But that's what 1/4 of them are dying from. And the rates of this are highest among black women and low-income women. So what can I do as a family physician? What can maybe my colleague in the other side, the nurse practitioner, the psychologist, the psychiatrist, what can we do to help reduce this hypertensive crisis or this heart disease crisis?
Yeah.
I mean, do you talk to women in your clinic about heart disease?
I do. I mean, and it's what I see is, we know heart disease is the number one killer of women, of people, of women in this country. Those conversations often start when they're older. They don't start when people are in their 20s or 30s. They're talking to people when it's already too late. They already have high blood pressure, right? Like, so we know those things if it's the food that we eat. But then you have to take it a step further. You can't just tell patients, well, eat healthier. You have to know the communities they're in, what they have access to, what they eat. And I really take a lot of time talking about food, because food is sacred to people. It's their culture. It's comforting. So you're trying to not just tell them go eat veggies and fruit all day, which I love fruit and veggies, eat it all day. But how do you really help people make those changes? Understand, like, well, if you work in a fast food place 8 hours a day and you can't leave, what can you eat there that's healthy for you? So we think about that. We think about movement, not just exercise. People think they got to go to a gym.
Staying active.
But stress is another big one we do not. Mental health affects your cardiac health. And that's where I think the black women top the charts, is the stress that is endured over a lifetime that's not addressed. So I think it's a level of, how do we take care of the health of a population way before they have the problem? And once they have it, let's not be aggressive. I feel a lot of people say, oh, you're young, I'm not going to put you on meds. Hypertension doesn't care. Your arteries don't care that you're 28. Your blood vessels are human, and blood vessels don't like high blood pressure. And so I think there's a lot of that kind of, you're young, it's okay, let's not treat this. I mean, I personally, and look how small I am, I had high cholesterol, right? 19 years old, I found out I had a 300 cholesterol, super high, right? And I got told for years, you'll be fine. Don't worry about it. No problem. But now, I'm over 40 and now it's a problem, right? Like, but that could have been, maybe prevented. But so I think we have to be much more proactive in our own
Right.
community. Um, we have to address those kind of the ways we eat, move, but we have to believe people too. And that's my big thing. I've seen a lot of people with hypertension come in, so they have
Right.
chest pain, and they're told nothing's wrong, and that's not
And what
right
shocks
either.
me the most is those who come in and say, "Oh, I was told to just drink not olive oil. There's another thing they
Apple
drink,
cider
apple
vinegars,
cider
yeah.
vinegar, and we have excellent medication.
Mhm.
And I'll say it here: I take blood pressure medicine
Mhm.
because I would rather trust in God, eat healthy, exercise, but I wouldn't want to put my neurological and
Mhm.
cardiovascular system
Mhm.
under strain
Yeah.
because in the interim my blood pressure is out of
Mhm.
control.
Yeah.
You know,
There's a balance. I think the problem with medicine a little bit is it's tried to push away like community and cultural
community.
wisdom, right?
Okay.
Like people have been treating blood pressure and healing themselves naturally for generations, and pharmacies aren't the only way. And I think our communities want a balance, right? They say take your medicine, but yeah, let's talk about these other natural remedies. And I think when there's a lack of trust there, if they don't trust the
Mm,
healthcare provider who says, well, don't do any of those things that you're you've been told in your family and community, but just take this medicine
this
that costs you
medicine.
money. There's a lack of trust there. I think there's balance that you can both, hey, take the apple cider vinegar and take your blood pressure medicine. I say do
Mm-hmm.
both. And I try to meet my patients in between. And
Living.
because, if you look at something, I think in America we'll call it like alternative, but like something like Chinese medicine is
It's
that
now
like
mainstream.
so it's like thousands. I mean, for them that it's thousands and
It's
hundreds
been,
of
yeah,
thousands of years old and proven. Just because it's different
wow.
doesn't mean it's alternative. So that's one way there. That's very integrated there. If you
Mm-hmm.
go to a hospital, you get both. You get traditional
Right.
and you get the
Western, they call it
Western or
Western.
like advanced kind of modern medicine. And I think every community has what they feel is going to heal them, and we should learn have some humility as doctors
Right.
and learn to meet
I
them where
agree.
they
I
are,
agree.
and that might bring more people in. And
I mean, a lot of medicines are actually from,
oh yeah, it derives from
from
some of that
plants,
stuff. Yeah, the same
So
thing with
it's just they were using it raw. They weren't processing it.
yeah, that's right, that's right.
Another question I wanted to bring up is the statistics you did, which was great in Mississippi
Hmm.
with the Perinatal Collaborative, said 86% of deaths in 2016 in Mississippi were postpartum, which
Yeah,
is
it's a high.
interesting, and more than 37 of them were greater than 6 weeks
Hmm.
after the
Yeah.
delivery. So um, what would you, what, so you think cardiovascular is still the number one cause postpartum? What
Cardiovascular.
will kill a woman after she's had the baby?
Yeah, so these reviews, how they're done, are really set by the Centers for Disease Control. Gives every state guidance on how to decide what caused this death, what was the cause of it, and was pregnancy the cause? And when we say pregnancy the cause, like we ask ourselves, if this person was never pregnant, what's the chance they would have been dead in this circumstance, right? And pregnancy kind of makes everything more extreme. If you have a little bit of blood pressure when you're pregnant, it's a lot. If you got a little diabetes with pregnancy, it's a lot. So pregnancy is almost like a stress test, right? So if you have a little bit of heart disease and you get pregnant, that heart has gone through a major stressor. And that stress doesn't heal immediately when the baby's gone. It takes a lot of time. We don't even know how long before or if it ever goes back to normal. So that strain is there on the heart and if you have someone who already had some degree of heart disease and then they died 3 months later, 4 months later, we ask ourselves, was she likely to just die this particular year if she had not gone through a pregnancy with the preeclampsia and the hemorrhage and the C-section? We say, well, chances are that had a lot to do with it. Kind of puts you on a track, right? And that track is either going slow or it speeds up. And
Speeds up.
pregnancy puts the gas on
Mm,
that. And so that's where, we say to ourselves now, if she had not been pregnant that year, maybe she was on that track. She was still a little overweight, high blood pressure, but it was not a train speeding towards death
right.
at the age of 35 or something like that. So what we when we look at also postpartum, um, Depression, suicide is a big thing we
Big
see.
thing.
An overdose, again, is in a lot of parts of the country, not so much in Mississippi, but a lot. We know the opioid crisis that has been going on. What happens is people get care when they're pregnant. They're motivated to care for the baby and for themselves when they're pregnant. They have health insurance to get help, and a lot of that gets cut off immediately after. The stressors of going back to work or not finding work, the stresses of, child protective services becoming involved if you were a substance user or law enforcement, and that depression gets severe and people rebound quite a bit. So it's very high risk period for overdose. Postpartum depression, literally we begin screening sometimes at 6 weeks postpartum,
Right.
and then people's insurance were stopping, so you couldn't even begin therapy or
Oh,
treatment.
do
And
anything.
so people are left, a lot of the model in America was, do that 6 week postpartum visit, and the next touch point was a year later. See you for your annual exam. So a lot of postpartum moms are just roughing it out
Roughing it
by
out.
themselves, or just and since we're not in those big communities where your mama and your aunt and your cousin and everybody's there to help, a lot of people are alone, and that depression much more
Wow.
severe, and we've seen a lot more of that. So beyond heart disease, which is certainly, I think, reflective of the lifetime of a community's health not being prioritized. That's what we're seeing now. This is all kind of additive. That's why the numbers are going up, because you're just stacking on the years and years of a community not having adequate nutrition. The subsequent generation's not going to get healthier. They're going to keep getting less and less healthy. We got to solve it at that level to stop those things. So that's why I see the numbers going up. We're also watching much more carefully, of course. We got better data. We're looking more closely. That's a good thing.
Yeah.
But that's what's kind
So
of
when
the
we
driver.
come back, we're going to talk a bit about the South and the statistics. In the South, we have a high, I think it's across the United States, but I think the South has a higher maternal mortality. But we're also seeing high STD rates,
Oh, yeah.
especially in the South. And I'm just curious if all that is related. And then thirdly, so you have um, the mortality rates are higher, you have high STD rates, then obesity rates are kind of higher here
Oh, yeah.
than in the North. So we're going to talk a bit about the South and see are there specific differences, if I may use that word, between the South and the North in terms of how their maternal mortality rates are compared. You worked in Connecticut, so you maybe can do a little comparison with your
Yeah.
practice in Connecticut, your practice in Mississippi, and you can tell us what you think was maybe responsible. Because we know that 47% of women will gain weight above the expected weight in pregnancy. So we're going to talk a bit about that. You don't want to miss it. Dr. Charlene Collier will be back. Don't miss it. She's going to be sharing her heart on obstetrics, on the social constructs around the increase in maternal mortality rate in America. Jesus is Lord. God bless you. Awesome.